Louise couldn't be here for this session, so she asked me to step in and do some background before introducing the fellows. Those of you who have been engaged with us in discussing the development of the preventive health research strategy will know that from the very beginning, developing capacity in the sector was one of the key strategies that was identified. So we felt safe working on this from before we had our strategy finalised, and I don't think we'll get any dispute from this room, I hope not. We launched the program, opened the program for applications about middle of last year, and were really pleased and delighted, if not slightly overwhelmed, by the number and the quality of the applications received, and that's always a bit daunting when you have to make those hard decisions. It was a rigorous process. We looked for the quality of the research proposed, but also the potential for the work to build relationships between policy and the research community, and that was a critical element in the applications and what we looked for, and I'm delighted that the three fellows that are here today were able to nail that, and I think show some real potential for working with us all as a community, but in their particular fields. We think this is an incredibly important step in leading the way, and I should say we're not alone in this. We actually drew very carefully and wisely on the knowledge of others that have worked in the fellowship field, particularly Vic Health and Healthway and others. So we don't see ourselves as doing something entirely new here, but we hope that it's extending and continuing to support and build that effort. So without further ado, I'm going to let Gail introduce each of the three fellows who are going to say a few words on the work that they're planning to do over the next few years. Thank you, Gail.
Okay, first of all, I'd like to acknowledge the traditional owners of the land and pay my respects to their elders past and present. The work that I'm talking about today, builds on a project that is also an AMFA funded grant, and some of you might have heard about that this morning when Professor Annette Meyer talked about it, and that is looking at the use, community perspectives on the use of regulation and law to reduce obesity in children in Australia, broadly speaking. This project that I have, that I will undertake in the fellowship, actually takes that and says, okay, well, what happens in an Indigenous context? And I think this was deserving of a project in its own right, because I think the problems are so enormous in our Indigenous communities. So the first part of the project will be collecting the evidence, and that will be looking at, well, what could be effective in reducing overweight in Indigenous communities, what impact will mainstream policies have on Indigenous people, and what do Indigenous communities think about is the role of government in addressing obesity in Australia and in their communities. The second part will be about fostering deliberation and debate in Indigenous communities more broadly, and that will be bringing together a group of people from a range of communities in South Australia only. I've restricted it to South Australia because it's too big otherwise, to engage in an informed deliberation. So the evidence that I'll bring will be partly evidence from the Healthy Laws Project, which is the broader evidence, but partly it'll be stuff that I will gather myself, material that I will gather myself to inform that debate. And the idea would be to try and create consensus. And the two questions that we'll be asking that deliberative forum would be which regulatory measures, if any, should be used to address childhood obesity. And the second question would be, if we undertake those measures, what supportive measures in particular are needed in Indigenous communities so that Indigenous people benefit equally as non-Indigenous communities. The final part of my project is actually looking at, my work will draw on deliberative methods, deliberative inclusive methods. And I'd like to know whether the theory that underpins those methods actually is, it aligns with Indigenous thinking and Indigenous norms and beliefs. So there's 3 parts to it: evaluation of evidence, an ethical analysis, and a study of Indigenous understandings. And all of this would be informed by the Healthy Laws study, but also would be guided by an Indigenous and possibly some non-Indigenous people. I've got a core group of Indigenous researchers that are helping, because I'm not Indigenous, so I need that support and from that group. And I'll be talking to them about how broadly we go. But there's lots of people working in Indigenous health that are non-Indigenous that would probably help to inform this project. The final part would be that deliberative cross-community forum. And what do we hope to get out of it? A justified, prioritised list of recommendations for legislation that's broadly acceptable to the Indigenous communities, and then also some advice to policymakers about what communities think governments should be doing and in this area, and the impediments and facilitators for those, and what required supports might be needed for effective implementation. And then finally, of course, we'd be feeding back to those communities, hopefully building some capacity within those communities to foster change, and a guidance document that will feed into the implementation of the new Public Health Act in South Australia.
So thank you to ANFA for having me today, and also for providing the fellowship, of course. So my project is going to be looking at young people and alcohol consumption and new technologies and social media. So just as a bit of background, as everyone in this room is aware, alcohol can be a major public health problem, and it's partly driven by a societal acceptance of excessive alcohol use. Another thing that's really common in society now is the use of new technologies. So I've got some stats up there about how common things like mobile phones and Facebook and other social media is in Australia. Australia has the second highest smartphone penetration in the world after Singapore. And a lot of research is showing, new research is showing that technologies both can be used for health promotion and social marketing, and they can also create problems. So I'm going to be conducting 3 separate projects, which I'll just talk about briefly. The first will be a review and evaluation of social marketing activities and health promotion projects using new media. That'll include apps and social networking sites like Facebook. There is a huge amount of interventions currently out there already using these technologies, but most of them haven't been formally evaluated. For example, my team did a review of sexual health promotion website or Facebook pages. They found 178 and only 1 had been formally evaluated. There are quite a few out there. For example, I've just published a review of alcohol apps on smartphones. Many are not evidence-based and may provide false or harmful information. And there's also some that are not necessarily bad, they're just not necessarily good. They may not be using the media to their best potential. So in this project, I'll be looking at what projects are already out there and reviewing their evaluation methodologies. And from that, I'd like to develop some guidelines or a framework maybe for conducting evaluations of these sort of projects, because it's quite difficult to evaluate these projects when there's no existing literature really on how to conduct these evaluations. So the second project, I'll be looking at alcohol advertising on social media and young people's perceptions of alcohol on social media. And so just from this screenshot, you can probably all see what a typical problem is with a Facebook page and alcohol. And it's clearly this here. In the corner there, there's an ad for wine that's been put up on my Facebook page. So this isn't really my profile picture, by the way. But it is a real photo. So what I'll be doing will be, if any of you were in the session in here just before, what Becky Freeman was doing, pretty much I would like to do something quite similar, but looking at alcohol instead of food and beverage. So I'll be reviewing what alcohol advertising is on social media, including explicit advertising, like direct sponsored advertising, and then things like fan pages and young people sharing information as well. The third study will be an SMS-based health promotion study. We'd like to conduct a randomised control trial, testing the impact of alcohol messages on alcohol-related behaviours. This is based on quite a bit of evidence in other health areas that it's just simple SMS messages can result in behaviour change. Finally, just some of the outcomes. There'll be some policy recommendations looking at either addressing potentially harmful activities and also endorsing beneficial activities. I'll be producing research evidence, obviously, and I'd also like to make recommendations to people conducting health promotion into how to create good health promotion using social media, and also how best to evaluate the impact of these activities. Thank you.
Okay, I'd like to thank AMFA for giving me this opportunity. I'm very excited to be embarking on this program of research. The title of my research fellowship program is How Costly is Childhood Obesity? An economic analysis of the consequences of obesity in Australian children. And my principal academic advisor will be Associate Professor Anna Peters, whom I'm sure many of you are familiar with. We already know a great deal about obesity. However, a number of important questions remain unanswered. For example, how costly is childhood obesity for Australia's healthcare system? Does childhood obesity lead to poorer academic outcomes and lower wage opportunities later in life? Through what mechanisms does adolescent obesity affect economic prosperity and well-being in adulthood? And are the economic consequences of obesity worse for children from lower socioeconomic backgrounds? Such questions are central to understanding the benefits of preventive action on childhood obesity. And they also help to identify opportunities to reduce long-term inequalities. So in my fellowship, I intend to answer these questions and many more similar questions. There are a number of components to my research fellowship, but essentially I have three main research objectives. And these are, first, to quantify the immediate and long-term costs of overweight and obesity during childhood and adolescence. And by long-term, I really mean the consequences of childhood and adolescent obesity that occurs later in life in adulthood. Second, to examine pathways through which overweight and obesity imposes such costs. For example, explore the extent to which lower economic prospects may be a consequence of workplace discrimination or health limitations. And the third objective is to investigate whether the whether the economic consequences of obesity differ by socioeconomic background. Now, throughout the research, I'm going to focus on three main types of costs. The first is healthcare costs, and here I'm particularly interested in the costs to Medicare. The second, productivity costs. So here I'm going to be looking at absenteeism and limitations in activities while at work. And third, perhaps the most significant, but also the most poorly understood cost is the cost the economic and wellbeing costs to the individual. So here I'll be looking at outcomes such as the completion of high school and tertiary education, employment opportunities, earnings, health-related quality of life, and overall life satisfaction. To conduct this research, I will be using nationally representative longitudinal data sets of Australian children, adolescents and adults. And I will employ econometric techniques to investigate the impact of childhood obesity on economic outcomes. And this work's really going to build on the work that I've been doing for the last 5 years at the Centre for Health Economics at Monash University, including my PhD on the economic consequences of childhood obesity. The main project outcomes will be evidence on the immediate and lifelong consequences of childhood obesity. And this evidence is really central to building a case for preventive action against obesity. More specifically, the project outcomes will provide information that's fundamental for appraising the current burden of childhood obesity in Australia, assessing the benefits of obesity prevention initiatives, modelling future cost projections and economic evaluations of obesity reduction interventions. So I hope to be able to meet and engage with many of you over the course of my fellowship. Thank you.
I hope none of you came here under any false pretences that this wasn't about showcasing some of the stuff ANFA's been doing over the last 2.5 years, because if you hadn't worked that out, you will have by now. But I hope you will also agree, and the fact that you're here, acknowledge that this is an important part of advancing the work in prevention, and that this is why the Preventive Health Research Fund was established under the National Partnership Agreement, and that this is a great opportunity to acknowledge some of the achievements of our researchers to date. Another part of ANFA's remit, a little outside of the partnership agreement, although there is a crossover with some of it, was to establish a national awards program. I partly blame Rob Moody for this, because I think he drew on some of the experience from Vic Health, but everyone I spoke to said that's been a fabulous experience over the years of recognising practice and excellence in practice, so there was no reason to shy away from that. And in thinking about awards, it strikes me that there are many other sectors that are very good at self-promotion and self-congratulation. The actors and filmmakers, of course, come to mind. So what the heck, why not in public and preventive health? But I think it's also a more serious measure, really important to promote good practice, to recognise excellence in practice, because that's how we share the experiences that we have and how we take time to recognise the hard work that many people have done, and then to use those learnings to take on into all of our work. So that's our intention with this award program, and that it won't stop on the day that we announce the award winners, that we will use them, and I hope you guys are up for this, to continue to engage with preventive health practitioners and researchers in understanding and learning from the practice that is recognised. The National Preventive Health Awards program had 6 categories for awards, and 3 of those were in the area of healthy workplaces, large, medium and small workplaces, and this was part of the program that was funded through the partnership agreement, and we've worked closely with the states and territories on that. We also launched awards for journalism, excellence in practice in Medicare locals, and of course research. The research category, I'm pleased to say, was the one that had the most award applicants, which was great, and fortunately not too daunting. We managed to work through that with a lot of support from our community of friends and experts in helping us with the judging process. The shortlisted candidates are here today, and we'll give you a brief presentation of the work that they presented for the award. The announcement, however, is not today. We have another big event for ANFA coming up at the end of July, on the 26th of July. It's been very confusing. 26th of June and 26th of July has got us in all sorts of muddles. But this will be the launch of the first State of Preventive Health report by our Minister at Parliament House, and incorporated into that day will be the announcement of the award winners at a luncheon. So it's great that you all could be here today to give this presentation, and we look forward to seeing you again in 1 month. So thank you, and we look forward to hearing from you.
So first I'd like to thank ANFA for the nomination. It's very flattering and humbling, and I must say somewhat embarrassing to be standing up here accepting or talking about an award that we're nominated for. You know, in a field like research, which is so kind of inherently collaborative, and particularly this project, you know, involves something like 30 staff over, 6 or 7 years. We worked with 20 communities that I'll talk about in a minute, and multiple policy agencies and government representatives. So it really is an honour to be here to tell you about the research. So ARC stands for, the other thing I probably should clarify is in your programs it says that the research is based at the Hunter Medical Research Institute. And I'm actually based at the National Drug and Alcohol Research Centre in Sydney, but the nomination was through there because Chris Doran's based there and he did all the health economic component for us. So we basically split the outcomes into two lots. So, what did we find in the economic analysis and what did we find in the main outcomes? So ARC stands for the Alcohol Action in Rural Communities. It was the main reason we wanted to do it was really the idea that I think Shelley was talking about this morning, where we tried to say, well, we know about some of the evidence about effectiveness in individual silos, so what schools do, what police do, what hospitals do, but we really don't have a good sense of what happens if all of those groups work together or do their things in a coordinated way. So that's what we wanted to test. I think from governments and WHO there's been a lot of rhetoric about, it's important that communities take responsibility for alcohol problems in their community. But that, it's an easy thing to say in some sense, and it's an assertion that had never really been tested. I think the rest of that's pretty straightforward. So these are the 20 communities that we worked with. I won't say too much about that. They're the 10 intervention communities, and then there are another 10 controls. So we just put them into match pairs and then randomly allocated one to each condition. And you can see those sort of, was all in New South Wales, and you can see those sort of fit in a band through the middle, and that really just reflects their population. So as you get closer to the coast, the populations get bigger, and as you get further west, they get smaller. So that's really why that pattern exists. So what's unique about it? It was a cluster randomised control trial, so that's the highest or the most rigorous level of evidence you can get. I think the second point there is a really important one. We're trying to take a whole of community focus. So everything we did, from the level of randomisation to the measures to the interventions, are all done at the sort of whole community level rather than individual drinkers. And the other thing that I do think is relatively unique about the ARC study is that we really tried to focus on using routinely collected data, and I still think there's enormous potential to use some of those data that are collected routinely in a way that we don't routinely do at the moment. So this just gives you really a kind of diagrammatic look at what we tried to do. So we tried to engage, there's some things that I think researchers have got skills in, looking at the evidence, doing the literature reviews, working out how to access and feed back data, and obviously our skills in doing, running trials and that kind of thing. So, but equally the communities and the policy agencies that we worked with each bring a different set of skills, and I think it's really important that what we tried to do was, as researchers, when we first went to the towns, there was a lot of, well, who are you to come from Sydney and tell us what our problems are? But I think that very quickly morphed into, there was a lot of goodwill and, particularly from our point of view, emphasising that we were there to support, their efforts and not just to take over and tell them what to do. So I won't talk too much about this, but we essentially did 13 interventions over about a 5-year period, and they were split into those types of categories. So I won't talk about them individually, but you can see essentially we tried to do some things around using better use of data. We tried to target high-risk groups, and we tried to do more frequent screening and brief intervention. I just thought I'd put this up because it's just an example of a media release that we put back to the communities, and you can see this is some sense operationalising the idea of involving multiple groups. So the green highlighted bits are the different people in the communities all commenting around one piece of data that we fed back, which is in that yellow highlighted group. So I think that's just an example of that collaborative nature. Of course, people had different views. For all of our feeding back data and talking about what the issues were, of course there were particular groups that disagreed, so there was a fair bit of working through that. So what impact did we have? The main headline outcomes are a 20% reduction in average consumption, and this is all relative to the control community. So they're not actual decreases in these things, they're just reductions relative to what happened in the control communities, and a 42% reduction in people's experience of alcohol-related verbal abuse. You can see a whole range there of things that were borderline statistically significant. So the 0.06s after 7 years were heartbreaking, but there you go. And then the economic analysis at the end showed that for every dollar that was invested in the ARC project, there was a return of between $1.37 and $1.75 in benefits to the community. I won't talk about this too much. I just thought I'd put it up though so you can see that really, this is the impact on total alcohol-related crime. And I think it shows, this is using police data, and it shows you, that pattern of results. So if you just look at the top two lines, the bottom one is the experimental communities and the top one is the control community. So you can kind of see that really the impact of ARC was probably to hold things steady rather than an ongoing increase in alcohol-related crime. So what are the main, I'll just summarise now the main outcomes. So there's research-specific outcomes, 35 papers, adding to, and it's, I know I'm a researcher, but I think it's important that, we kind of contributed to building capacity to do this type of research. There's a range of community-specific outcomes there that you can see. And I think the main policy implications are really, that the idea of community action, I think, can have an effect, as you've seen. But really, if you want to actually decrease harms, or if you want to reduce the more serious things like assaults, traffic crashes, we didn't impact on those at all. So that's probably, where you need complementary legislative approaches and things like price controls, register availability, and advertising controls. And I think that sums it up nicely. I thought that was priceless. So this is the newspaper in Dubbo reporting the success of the trial right next to the alcohol ad. So I think that's a good place to finish. And the full report's available on the Foundation for Alcohol Research and Education's website, and the main papers are under review now. So thanks very much.
Thank you, Gail, and thank you to ANFA for the invitation. It's great to see the leadership that ANFA is providing prevention work in this country. I'd like to acknowledge the traditional owners of the land that we're meeting on and pay my respects to elders past and present. Okay. So a decade ago, Australia was confronted with a seemingly uncontrollable epidemic of child obesity, overweight and obesity. And as a consequence of that, all of the governments across the country initiated a series of policy initiatives to try and identify what government should do and what communities should do to address that. Those sorts of initiatives included state level and national level action plans, and also the conduct of a number of states, a number of jurisdictions, obesity reduction summits. Thank you. In New South Wales in 2002 there was a Child Obesity Prevention Summit run by the state government, and as a consequence of that there was an action plan developed and a range of different obesity prevention initiatives implemented. One of those initiatives involved a very large-scale whole-of-community intervention conducted in the Hunter New England Health region of New South Wales. That program, titled Good for Kids, Good for Life, was a whole-of-community approach, very similar, if you like, to what Anthony was speaking about in his presentation. It was a primary prevention program, and it was a dissemination program focused on disseminating either proven or promising intervention strategies that have been demonstrated through research to be effective. The objectives of the program was focused on addressing overweight and obesity amongst children 3 to 12 years of age. It had 4 primary objectives. One was to increase parental awareness of the determinants of obesity and the evidence-based strategies for addressing those, to build preventive capacity in community organisations, to change children's behaviours, key determinants of a child overweight and obesity, and to reduce the overweight and obesity prevalence in the district, in the region. The latter aim was, in a sense, the goal, the vision, if you like, but there was a realistic expectation in the period of the program that might have been a bit of a stretch target. However, that was, in a sense, what drove the government and ourselves and the community to become engaged. The approach of the initiative was a dissemination program, as I've indicated, focusing on proven or promising programs. To identify those, we undertook a fairly extensive consultation process with local, regional and state stakeholders and experts to identify the initiatives that all levels of partnership were comfortable with in implementing. We had an explicit goal of building the capacity of community settings to deliver those particular programs and initiatives, and we adopted an explicit practice change or translation model for those particular community settings. That model of change was based on the literature from a range of different human service organisations, and it involved developing leadership in each of the different settings, developing systems, programs and policies in different settings to promote the initiatives, to build the skill levels of the staff and the workforce in each of the settings, to implement a performance monitoring system to support those settings in delivering the programs, and finally, to effect all of those organisational changes in each of the settings to provide resources to support that change process. The settings that the planning workshop and process identified for us, we identified 7 different settings in the region, in the community: Aboriginal and Torres Strait Islander health services, primary schools, childcare services, sports clubs, GPs and practice nurses, community service organisations, and their organisations which provide home visiting services to disadvantaged families, and a broader social marketing campaign to support the overarching program. By definition, there's a lot of engagement and energy and investment required to bring those different settings together to work towards a common cause, and that involved the establishment of a large number of different partnerships with each of the settings and with different sites and organisations within the settings. We needed a partnership between New South Wales Health and Hunter New England Health, the funders, and also a partnership was formed between the University of Newcastle, University of Sydney and the team itself to conduct the evaluation. The evaluation of this, given it was quite a complex and broad scale evaluation, there's a number of different types of evaluations. In some instances there was quasi-experimental designs, in other situations there was simple pre-post evaluations. In terms of parental awareness, in terms of an outcome, we conducted a quasi-experimental design where we compared parental knowledge amongst parents in the region to the state, and we identified there in the region there's a 59% awareness amongst parents of the issue of child obesity and of the key determinants and of strategies to address it. And that was roughly a 4-fold higher prevalence of awareness and understanding than the remainder of the state. In terms of building the prevention capacity of those various community settings, we were able to reach and work with 59% of the Aboriginal and Torres Strait Islander health services in the region to build the capacity of staff to address obesity issues and determinants. We reached 69% of the primary schools in the region, and that was compared to 9% of schools in the remainder of the state addressing the same topic or the same program. 80% of childcare services were engaged, again markedly higher than the remainder of the state. 41% of sports clubs adopted the program. Up to 70% of the practice nurses were engaged, and 80% of the community service organisations were involved in the program. So in each of those cases, we were able to go into those settings and implement our practice change model such that those settings were, in a sense, structurally modified and hopefully able to deliver the programs on a sustainable basis. In terms of the outcomes in child behaviours, we had significant reductions in children's fruit, juice and soft drink consumption, significant reductions in a number of children having no physical activity, and a reduction in the proportion of children who are exceeding screen time guidelines. We had significant increases in the prevalence of children consuming water and are meeting both fruit and vegetable and physical activity guidelines. In terms of overweight and obesity prevalence, we achieved a 1% decline per year for children across the 5 years of the program and across all age groups. And we had a particularly strong effect in children 5 to 10 years of age and a significant effect for 5 to 10-year-old girls in particular. In both of those outcomes in terms of weight, that was relative to a stable trend across New South Wales, which suggests a differential effect in the region as a consequence of the program. So in terms of translation, what we think we have achieved is that we believe that the evidence, what is evidence, the evidence available regarding the determinants and strategies for preventing child obesity, we believe we've increased parental awareness and ability to act on that information as a consequence of the program. We believe we've enhanced setting engagement in the prevention of obesity generally. We've dramatically increased the reach of programs that were available but not yet fully adopted by settings in the community. The dissemination model, the practice change model, has informed the New South Wales rollout of obesity prevention programs subsequently to our program. And the model itself has been taken up more extensively within our own population health unit, not only in obesity prevention but in terms of other preventative activities. We invested in ensuring that there was commitment to disseminating the findings more broadly in the research community. 11 papers have been published, 16 conferences plus been presented to. And in terms of building the translation capacity amongst researchers, we've trained 4 PhD students and had 1 fellow supported. Finally, I'd like to acknowledge the large number of players who contributed to the success of this initiative, all of the community setting and partners in particular, the Good for Kids team itself, the funders, New South Wales Health and Hunter New England Health, and the University of Newcastle and Sydney for evaluation support. Thank you.
Thank you very much for having me. I'm going to take a little bit of a different tack because our nomination is about some community-led alcohol and other drugs research conducted since 2005 in Arnhem Land in some remote Aboriginal communities. This work is part of our broader efforts to improve access to local Aboriginal people about evidence-based options to address substance misuse, which cause so much harm in so many communities, and also about how to mobilise communities to develop and devise their own solutions to these issues. Today I'm presenting our work on behalf of Good Island Health Clinics, the Perfect World Film Company, and Dilakwa Land Council and the University of Sydney, and also the communities themselves. These are really strong partnerships which we've built over 8 years or so. I don't have many words, it's just a bit of a picture slideshow for you, but the 3 communities where this work was conducted, just to give you an idea, east of Darwin, around 600 kilometres, and they're located near to a mine and they're really physically isolated and beautiful, as you can see. There's about 1,700 Wanmamalia or local Aboriginal people living there and 1,000 Wurmangatara or non-Indigenous people. Traditional culture is very strong, including bush hunting, like this big bucket of yuokura, mud mussels, and 1 Aboriginal language is the first language of all community members, including newborn babies. This picture, drawn by 2 local artists, shows some of the drugs used in these communities. So we see in these communities that if we look at tobacco, around 9 out of 10 people smoke. We know from our research that many mass-produced health messages just aren't understood because of the local worldviews, which really contribute greatly to people's awareness about, or lack of awareness about, harms from tobacco. In terms of alcohol, or Anija as they call it, there's been a really successful liquor permits program in place since 2005, and Professor Peter Dabbs, who's here today, was part of evaluating that, that program, and it saw reduced domestic violence and police call-outs. However, many people still drink heavily, particularly when they go out of the community, so to Gove, to Darwin, to Cairns. So the intoxication itself is not generally seen in the communities, but the harms and impacts on the families certainly are. Our research has also found that cannabis in particular is a significant community concern. So we see it being linked to violence to people or property by users when supply runs out. It has a really high economic impact, but it's also seen as a good thing if you compare it to previous decades when people were sniffing petrol or drinking alcohol. This work contains the only longitudinal study looking at cannabis use amongst Indigenous Australians Australia-wide, and the only study worldwide to look at cannabis use and depression, so an association study in an Indigenous population. But how do we get some of this health research back to whole communities and to policymakers and to all of the other stakeholders? Well, for us, translational research has been a fundamental part of the work. Our team of local Aboriginal researchers, 11 of them, wanted to find a way for everyone to understand their research story. So not just the people in Darwin, not just the leaders who are used to reading reports, but also your 12-year-old boy and his grandmother. But in the local context, there were so many intriguing challenges with a numbering system that only goes up to 10, so it was really hard for me to tell someone findings for the 25 to 30-year-olds. Also different concepts for understanding why disease happens, so the causation of disease, including very routine and regular belief in black magic. So months of work and checking with these community members and others across the community, so from older people to younger people to linguists to health workers to council members, etc., helped us come up with these guys who were commissioned by a local artist. I told you it's all pictures, sorry. So we can see here from left to right, we've got the Wurundjeri, the man with the wallaby on his head, the Wuddaringa, the woman, and moving across the Wurundjeri, the teenage boy, and then the teenage girl, the Wurundjeri. So each represents the life stages of people in this sample using local Aboriginal concepts, and it's interesting to show it to nearby communities because they very much understand the research findings based on these pictures, even though these were just devised from this community. The local researchers very, very quickly tossed out the idea of using prevalence tables or population pyramids like what you might see in other household surveys. It just wasn't suitable for this local audience. Instead, they came up with their own locally devised way to present what I say to them, numbers data or quantitative data. And this is an example of one of those. So you can see here the lighter figures in each of the 4 quadrants are the cannabis smokers, chosen that way by the local researchers because they look a bit less healthy, a bit faded away, like their spirit isn't there. So for the Wurundjeri, the man with the wallaby on his head, in the top left, you can see out of every 10 men, so this is age 13 to 36, 7 were using cannabis, and in this community that's typically very heavily, so 6 or more cones each time they smoke, which is pretty much every day. Community members and health workers said they'd never had quantitative findings translated back to them in this way, and this way of communicating the findings has really generated lots of community interest to improve health literacy and to have these conversations about substance use and the harms that they see, as well as interest Australia-wide from urban through to remote Aboriginal communities. But interestingly enough for me, it's also led to a really particular interest from these guys in using film to tell stories about health issues that these guys suggest. So pretty much over the last 7 years, they've had me producing over 10 films just about, all stemming from this research. So we started with films about cannabis and mental health, and a year and a half ago, we launched a film about alcohol. I couldn't show you the film, I couldn't get it working with the computer, but this is a promo shot from this film called Anaja, which is on problem drinking. And we were asked to do it by senior community leaders who, after the liquor management plan, still really wanted more health promotion around alcohol and its harms that are seen. This film won Best Indigenous Resource at the Australian Teachers of Media Awards in 2011. So as I mentioned before, the film is called Anaja. It means alcohol in the local language, and it tells the story of this young guy, Roy. He's 10 years old, and his younger sister, Desley. Their parents drink too much, and the only person that they can trust, their grandmother, lives very, very far away. So different to other educational or documentary style films, Anaja uses drama, and it was completely devised with the community with no script. So it's spoken in their language and translated back into English by way of subtitles. And it tells the story of this family's struggle to deal with the problems from alcohol. It's been interesting looking back when we were preparing the nomination to kind of see, we're really pleased that some of the research has been taken up by the NT government by way of the police, as well as by way of current reports they're writing at the moment for the Legislative Assembly into cannabis use and harms. It's been taken up by the local stakeholders, the health workers, the police, etc., and the schools. But most importantly, I think it's been just really taken up by the communities, and it's been quite a process to see how the conversations about cannabis and what we can do about it locally have really come very far. Even to now, they're about to hold a summit into substance use locally in the area, which brings together the NT government, the federal government and local stakeholders to talk about it, whereas I think the health workers were saying to me there's just no way they could have done that, 8 or 10 years ago. So they've come very far, and I'm, very honoured to be presenting for them to you guys today. Thank you very much.